Good evening, everyone. My name is Devon Mings. Um, you are currently attending HiSig's presentation. Today, we have Patrick with us presenting on innovations in artificial lung devices, and we'll be getting started shortly. We'll wait a little bit longer um, for some more people to join, and at that point, we'll get started.
Patrick, thank you for attending, sir. Looking forward to hearing your presentation this evening.
Devin, please let me know when we're ready to go.
Will do.
Mr. Mings
Will do.
will let us all know when it's time to begin. He is the leader of the event this evening. Thank you, Mr. Mings.
Not a problem. Thank you. Thank you, Tony.
Good morning. You have to turn the sound on if you want the sound on.
I'm not sure you're ready to play there just now, but in case you are, yes, the sound is not coming through.
It's coming through on his end. He may not hear us. Devon, can you hear us?
I can hear you. The sound is not coming through on your end?
No,
No,
sir.
you have to choose the option to allow sound at the top middle of the screen. The icon
Say again.
that shows
Say again,
the,
Alfred.
the icon that shows the computer icon. You have to click it to say allow sound.
Okay.
Top middle. Or you can stop share and reshare your screen and choose the option to include computer sound. Did you find it?
No, I did not.
At the top of middle of your screen, where you
Top
spread
middle.
your screen, top middle, the bar
Yeah.
will come up. In that bar, there's an option to say allow sound. Or you can stop sharing, and when you reshare, choose the option to include sound.
Okay, I'll try that. Did that work?
Yes, sir, it did. You're good.
Great, thank you. Okay, I think we are at a point where we will begin. Patrick, I will share a few slides before I introduce you, and then you can take the floor. I'd like to welcome everyone today to our presentation of innovations in artificial lung devices. At this point in the program, I'd like to pass it to the HISIG director. Alfred, please take it away.
Hey, good morning, good afternoon, good evening. I know you guys are joining from all over the world, but I'm excited because we get another opportunity to share relevant information for this community to you guys. I'm excited because the work that this team is doing in terms of educating the community on projects, research that people are doing is not only what I would call beneficial, but it also introduces new ways of thinking about the research that we do and helping other people. Folks, the team at CMU have been long partnered with us in terms of building out the regionalized initiative for making sure that the NSBE HISIG mission continues to be realized in other locations. So my excitement today is because of the work that Patrick is doing. It's almost sort of like the first step in how do we get that information out to you. We have so many programs coming that are really intended to create more discussions for you guys. So as we go through this content, I'm asking the team to take notes. The content, the session will be recorded, it'll be available for others, and we're going to ask that you share it out with other folks. While we're doing that, if there are other individuals that are in the healthcare space that need to have this message, we would absolutely encourage you to invite them to this call, and we'll post the link to the meeting so that you have access to it. This is an opportunity to ask questions and be involved and share your work as well. And then lastly, if you have work that you want to share on this forum, we would gladly love to have you join us and be a part of the presentation so that we can learn about the work you're doing and see how it's relevant to our community and to its constituents. Again, I'm excited because this is an opportunity for us to share the content. thank you, Devon, again for taking the time to help coordinate this. And I really am looking forward to hearing the message that Patrick has to share and the work that he has to share as well. So without further ado, I turn it back over to Devon and then he can introduce our speaker.
Great. As we continue, just a few housekeeping items. Audio and video settings, please mute your audio and also turn off video feed as well. Chat communication, please use chat feature for questions or issues. Post all messages to everyone, no private chats or direct messaging. Also, Q&A guidelines, hold questions for Q&A sessions at the end of the meeting, where we can have a nice exchange with Patrick at the end of his presentation. This is the meeting agenda that we will be trying to stick to tonight, and just for your information. At this point, I would like to pass the floor. I would like to invite Tony Black, our HiSig advisor, to speak to you about HiSig's mission, vision, and our care strategy. Tony, I invite you to the floor.
Thank you, sir. I appreciate that. I just want to briefly go over our mission, our vision, mission, and care strategy. So for our vision, we simply want to be the most trusted ecosystem for technical expertise, solutions to complex healthcare problems impacting the Black community. And our mission is to promote the development of and implementation of innovations that will improve diagnosis, treatment, and prevention of injury, illness, and disease across the Black community. Next slide, please. Just to briefly go over our care strategy. Our care strategy is made up of 4 concepts: connect, advance, recruit and retain, education and expose. So the care strategy is really breaking it down to connecting members of interested in healthcare innovation within professionals in academia, government, industry, and mentorship, professional development, and career opportunities. Advancing the healthcare innovations through research, development, and commercialization. In addition to recruiting and retaining NSBE members interested in healthcare innovation and educating and exposing those members in the Black community to healthcare disparities and innovations and careers. That is essentially our care strategy across HiSig. And as you can see, our graphic off to the right, how that illustrates the different entry points of how you can connect, integrate, and align with our care strategy. And if you have any requests, suggestions, recommendations, or questions about how you can be involved and engaged with our care strategy, please reach out to us. And at this point, I'll turn it back over to Mr. Mings. Thank you, sir.
Thank you, Tony. I appreciate that. At this point in the program, it's what we've all been waiting for. Patrick Iyasele will be presenting on his research in the innovations in artificial lung devices. Patrick is a PhD candidate at Carnegie Mellon. And Patrick, I'd like to invite you to the floor to continue with your presentation.
Right.
I will stop sharing and let you have the floor.
All right. Let me share my screen. Is my screen available to everyone?
Yes.
Right. Hello, everyone. Thank you for coming to my talk about innovations in artificial lung technology. My name is Patrick Iyasele, and I am a third-year PhD student at Carnegie Mellon University, where I work in the Cook Cardiopulmonary Engineering Lab. In this presentation, I will present the conditions that are treated with artificial lungs, along with presenting how they work. I will then go over what issues currently used artificial lungs have, and then go over the different areas of research or lab studies to try to remedy these issues. Chronic lung diseases cause a gradual decline in respiratory function. These diseases increase the work of breathing, which is the amount of energy required by the respiratory muscles to inhale and exhale. The most common symptoms are shortness of breath, coughing, and excess mucus production. The most common chronic lung disease is COPD, or chronic obstructive pulmonary disease. COPD affects 15 million Americans and has two major subtypes: chronic bronchitis and pulmonary fibrosis and emphysema. Sorry. Chronic bronchitis is caused by excess mucus in the and inflammation in the airways, leading to the restriction of airflow. Emphysema is caused by the destruction and loss of alveolar membranes. This reduces the total alveolar surface available for gas exchange, leading to a reduction in oxygen supply for the blood. This condition can cause acute exacerbations, which are periods of severe deterioration of respiratory function. During these events, COPD patients are often hospitalized. COPD is most often caused from exposure to noxious particles or gases, and the most common form of this is cigarette smoke, but it can also come from air pollution or other chemical fumes. Pulmonary fibrosis is the second most common chronic lung disease. It affects 200,000 Americans. Pulmonary fibrosis occurs from the scarring and thickening of the alveolar membrane and surrounding tissue. This thickening decreases the oxygen transfer capability of the alveoli. Similar to COPD, pulmonary fibrosis causes acute exacerbations, and pulmonary fibrosis occurs from exposure to prolonged occupational or environmental irritants. This disease is very common in coal miners from coal dust, known as black lung, and it's also found a lot in construction workers who work with asbestos or from concrete dust or sawdust and fungus. Chronic lung diseases have no cure, but symptoms can be treated and the progression of the disease can be delayed. Bronchodilators can be used to open up the airways, corticosteroids can be used to decrease inflammation, and antibiotics can be used to combat infections during acute exacerbations. Often, non-invasive ventilation may be used to support breathing and also reduce daytime breathlessness. This is usually through an oxygen mask or nasal cannula. As I said earlier, uh, patients with chronic lung disease often have acute expirations where the respiratory function temporarily decreases. During these acute exacerbations, non-invasive ventilation is often not sufficient to sustain a patient. The next standard treatment in this is mechanical ventilation. In this treatment, a endotracheal tube is inserted into the patient's trachea and oxygenated air is forced into the lungs. Although effective, uh, this intervention has a risk of significant complications such as sepsis, lung collapse, and pulmonary edema due to lung trauma from the lung being placed under too much pressure or by a too high volume of air being forced into the lungs. There's also a chance of ventilator associated pneumonia due to an infection caused by the endotracheal tube being placed into the trachea. The gold standard treatment for severe chronic lung disease is a lung transplant. It is the only restorative treatment, as there is no currently available treatment that can restore lung function. The issue with lung transplants, like any other organ transplant, is the lack of donors. Only 3,000 transplants take place each year, and the number of candidates added to the lung transplant list outpaces that number. Because of this, artificial lungs, or ECMO, in recent years has increasingly been used as an alternative to mechanical ventilation for short-term respiratory support as these patients wait for transplants to become available. ECMO stands for extracorporeal membrane oxygenation. The system contains two main components, a pump and an oxygenator. An ECMO system pumps blood from a drainage cannula connected to the inferior vena cava through an external oxygenator and returns blood through a return cannula. The oxygenator is where oxygen and carbon dioxide transfer occurs. Gas exchange in an oxygenator occurs from the interaction between blood and a hollow fiber membrane made out of polypropylene or polymethylpentene plastic fibers. Oxygenated air flows through the fibers and blood flows around the fibers. The fibers are between 200 and 300 microns in diameter and are permeable to gas, but not to blood. Oxygen and carbon dioxide can diffuse through the membranes of each fiber, and collectively, the oxygen transfer of each fiber provides enough oxygenation to sustain a patient. Gas transfer is directly proportional to surface area, so oxygenators have a surface area between 0.5 meters squared and 2.5 meters squares. Interestingly, this is a lot less than the surface area in your lungs, which have a approximate surface area of 75 meters squared, or approximately the size of a tennis court. So ECMO has been used to treat patients in both short-term and long-term usage. In the Trudzinski study, they treated patients that had acute respiratory failure from interstitial lung disease with ECMO. These were patients that were too sick to receive a lung transplant. 14 out of 15 of these patients died after an average of 40 days on ECMO. And as you can see in this graph, ECMO performed well for the first 3 weeks with a survival rate in the 80%. But after a month, the survival rate decreases greatly. This shows that ECMO works relatively well for short-term usage, but not for long-term usage. One major issue that comes to mind when trying to use ECMO for long-term usage is the balancing of clot formation and bleeding risk. So blood coagulation is the body's mechanism to form a stable blood clot to stop bleeding and allow time for the tissue to be repaired. It exists as a cascade of factors leading to clot formation. The cascade is split into the intrinsic, extrinsic, and common pathways. The intrinsic pathway on the left side of this chart begins from artificial surface interactions, starting with the activation of factor 12. The extrinsic pathway begins from tissue damage, for example, a cut. The extrinsic pathway starts with the activation of factor 7. Both of these pathways lead to the activation of the common pathway. The common pathway begins with the activation of factor 10. This leads to the conversion of prothrombin to thrombin and the conversion of fibrinogen to fibrin, thus finalizing clot formation. ECMO is a highly procoagulant system. Clot formation in ECMO can cause a decrease in gas transfer in the oxygenator and increase blood flow resistance, which then requires the pump in the system to work harder. There's also the chance of clot formation breaking off and returning to the patient to cause a stroke or embolism. The procoagulant environment of ECMO is due to its endothelial surface, abnormal blood flow, and its creation of procoagulant substances. The plastic fibers that provide gas exchange in the oxygenator are hydrophobic and provide ample space for protein absorption. This protein deposition on the surface creates spots for clot formation. The same large surface area that allows for sufficient gas exchange also increases the probability of clot formation. Both the oxygenator and the pump in ECMO causes abnormal blood flow. Shear stress from the pump can cause coagulation, and the complex flow patterns inside the oxygenator can cause low flow areas. That provides an increased chance for coagulation. The pump can also cause the destruction of red blood cells due to the forces it impacts on the blood. This causes hemoglobin to be released into the blood plasma, which is a procoagulant substance. Heparin is the standard anticoagulant used in ECMO in the clinic. It is given intravenously. Heparin anticoagulation is mostly due to it binding and activating antithrombin, which then binds to factor Xa. Binding to factor Xa prevents the continuation of the coagulation cascade by preventing factor Xa from converting prothrombin to thrombin. If we remember this chart of the coagulation cascade, heparin prevents the clot formation during the common pathway. This means that it prevents clot formation from both artificial surface areas, which we want, but also from tissue damage. So we want to prevent coagulation in the ECMO circuit due to artificial surfaces, but heparin also prevents blood clots in response to a cut or an injury. In one study, the rate of having a bleeding event during ECMO is as high as 29%, and the risk of a major bleeding event is 10%. And also the risk of having a brain bleed is between 4 and 10%. Because of the risk of bleeding and negative effects of clot formation, heparin usage during ECMO requires close and frequent monitoring. Heparin, due to how it works, does not help in this way because the anticoagulant effect of a given dose is different between patients and can change over time. Heparin recruits antithrombin and is used up over time, which means it needs to be restored by the liver. Different patients may have different starting amounts of antithrombin in the body, and if the patient also has liver damage, the refilling of antithrombin in the body can be decreased. These effects combined create an unpredictable anticoagulant response requiring frequent dose adjustments and anticoagulant monitoring. The second major issue in implementing long-term ECMO is the limiting of patient mobility. Patients have limited movement in the ICU while being treated, and neuromuscular weakness is common when immobilized during critical illness, and physical movement is associated with shorter hospital stays. In one study, patients that undergo physical therapy during ECMO had a 100% survival to discharge rate compared to 64% for the rest of the ECMO patients. This therapy only consists of walking around the intensive care unit hallways once per day. Because of this effect, physical therapy for ECMO patients has increasingly become standard practice. The issue with this therapy is that it's very resource intensive for the intensive care unit to do it. Patients in physical therapy need assistance from multiple people to carry around the large ECMO system and monitor their safety. As you can see in these images, you see the amount of people that has to carry around all the equipment for these patients. They need all these people to monitor their safety because any kinks in the circuit tubing or tugging at the cannulation sites could create adverse events. This problem limits how long and how often physical therapy can take place, as it takes human resources away from treating other critical patients in the intensive care unit. The balancing of clot prevention and bleeding risk along with concerns of patient mobility, leads to two major goals in our lab's research. We desire to create a simpler and safer anticoagulation strategy and create a smaller and more portable ECMO system. We desire to move patients out of the ICU and in the future eventually allow people to stay at home while using ECMO. Our strategy to create simpler and safer anticoagulation management is twofold. Our plan is to test anticoagulant surface coatings and explore using previously discovered anticoagulant medications with ECMO. Anticoagulation coatings are studied to prevent surface-induced coagulation caused by platelet adhesion and protein absorption in the ECMO oxygenator. These procoagulant sources are significant ECMO circuits due to their high surface area, and polycarboxylbetaine, or PCB, has been shown to limit platelet adhesion and fibrinogen absorption to 23% and 10% of the baseline values. This occurs because PCB is a Zwitzer ionic compound, meaning that it consists of alternating positive and negative charges while remaining net neutral. The charged segments of PCB attracts water molecules, which forms a thin water layer that repels protein absorption and platelet adhesion. In one study, miniature artificial lungs were coated with PCB, and these PCB-coated devices maintain a lower blood flow resistance than an uncoated device and had a lower device failure rate over a testing period of 36 hours. Another anticoagulation strategy we are developing is the usage of targeted short interfering RNA, or siRNA, to silence the production of factor 12 in the liver. Limit the production of factor 12 for a few days to a few weeks. As I previously stated, coagulation cascade can be split into the different pathways, intrinsic and extrinsic. The intrinsic pathway, which starts from artificial surface contact, begins with the activation of factor 12. Preventing or limiting the activation of factor 12 would prevent clot formation in response to artificial surface interactions while maintaining the coagulation due to tissue damage in the extrinsic pathway. Factor 12 silencing in ECMO should prevent the increase in bleeding risk caused by other anticoagulants. A single siRNA dose can reduce plasma protein concentrations within 1 day. Once siRNA enters the cell, it binds to RNA-induced silencing complex and degrades target messenger RNA that codes for factor 12, preventing its production. In a study done by our lab, we used siRNA to silence factor 12 in the rats, and then attached a small ECMO circuit to that rat. The amount of clot formation was not statistically different between the siRNA and heparin groups, but it was significantly different from a no anticoagulant group. Another method of inhibiting factor 12 is by using a small peptide inhibitor called factor 12-900. In previous work, we have shown that factor 12-900 is able to maintain a lower resistance and lower clot formation when used in a rabbit-sized ECMO circuit when used with the PCB coating, as you can see in this graph. It was able to do this without increasing the bleeding time, which is the measurement of how long it takes for a small cut to clot off in the subject. The main issue with factor 12-900 is its short half-life, which is predicted to be 1 hour in humans. This would require that it would have to be given intravenously in a continuous infusion to maintain the anticoagulant effect, making it unsuitable for the goal of making ECMO usable at home. We are working with our partners at Cornell University to attach factor 12-900 molecules to the PCB in order to increase its half-life. Attaching factor 12-900 to PCB should increase its half-life to 24 to 48 hours while maintaining its anticoagulant effect. Right now, our partners at Cornell are optimizing the synthesis of factor 12 900 PCB conjugates to maintain stability. We will, once that stability is maintained and synthesis process optimized, we will then test the formulation using our rapid scale devices. Different from creating anticoagulant coatings and factor 12 inhibition is our lab's work in looking into using previously developed anticoagulants to use with ECMO. We are currently working to determine if rivaroxaban can be used with ECMO. Rivaroxaban, also known by the name brand Xarelto, is a direct oral anticoagulant, or DOAC, that is currently approved for the treatment of deep vein thrombosis and pulmonary embolism. Rivaroxaban is given orally through a pill instead of through an IV like heparin. Similar to heparin, rivaroxaban is a factor 10A inhibitor. This means that the balancing act between clot formation and bleeding risk is still present, but what makes rivaroxaban potentially better than heparin is that it inhibits factor 10A, but has a much flatter dose response. A flat dose response means that the anticoagulant effect does not greatly change with the dose given. If you look at this graph to the left, it shows the factor 10A inhibition effect over time due to different doses of rivaroxaban. The black triangles in this graph is a 10 milligram dose. The white triangles is a 20 milligram dose, and the black diamonds is a 40 milligram dose. Even though there is a doubling and even quadrupling of the dosage, the inhibition effect is still very similar. A double dose does not have a double inhibition effect. This makes rivaroxaban useful as you would not need to adjust the dose nearly as much as heparin to account for age, weight, gender, or the health of the patient. Our first area of ECMO device development is the biofabricated lung. Endothelial cells have a natural anticoagulation property that regulates clot formation in the human body. Their absence is one of the major reasons why ECMO is highly procoagulant. A solution to this could be to create a tissue-based artificial lung. The device would consist of thin alternating blood and gas collagen 1 channels. The collagen would be seeded with induced pluripotent stem cell derived alveolar type 1 and pulmonary epithelial and endothelial cells. This device is fully composed of biological materials as opposed to artificial surfaces that can trigger clotting. Using collagen 1 as a substrate provides the endothelial cells a biological substrate as opposed to artificial surfaces in ECMO that is hard to endothelialize. The cellularization of the device with these cells will provide a barrier between the blood and the gas channels and allow for gas transfer while maintaining an anticoagulant environment. We are still in the beginning stages of developing this, but our current goal is to develop a rat scale biofabricated lung. Our second area of ECMO device development is the pulmonary assist system, or the PASS. The PASS consists of a commercial small, lightweight ventricular assist device axial flow pump, an in-house developed biocompatible gas exchanger called the pulmonary assist device, or the PAD, and a custom device monitoring system. The PAS is designed to be worn by the patient and have a small footprint. The system's high biocompatibility and small size and weight will enable long-term ambulatory respiratory support for COPD patients in a hospital or eventually at home. Compared to ECMO systems currently available on the market, the pulmonary assist system is rated to properly oxygenate at a lower blood flow between 2 and 4 liters per minute compared to the 2 to 7 liters per minute and of commercial devices. It also has a lower blood flow resistance between 2.5 and 3.5 millimeters of mercury per liter per minute compared to the 5 to 10 millimeters of mercury per liter per minute of commercial devices. In our lab, we have tested the pulmonary assist system by attaching the system to a sheep. In a study that I led that was just completed in this past November, we attached the system to a sheep for 10 days, and then we used the rivaroxaban as the anticoagulation management. The study was done to provide evidence that rivaroxaban, along with the pulmonary assist system, could properly anticoagulate for short-term ECMO usage. We administered 0.75 milligrams per kilogram of sheep weight dose of rivaroxaban every 4 hours, which is much higher dose than what would be in humans. A normal human dose is 15 to 20 milligrams of rivaroxaban once daily. Sheep process rivaroxaban much faster than humans. We monitored the blood coagulation, the oxygen transfer capability of the system, blood flow resistance, and the animal's general health. We conducted 5 trials of this study. Over the 10 days, the blood flow resistance did not significantly change. The average resistance in the 10 days was 3.04 millimeters of mercury per liter per minute. The oxygen transfer capability of the device decreased slightly over the course of the study. It maintained an average of 120.2 milliliters of oxygen per minute. For context, at rest, the average person uses around 200 to 250 milliliters of oxygen per minute. So our device can provide about half the oxygenation of an average adult requires. A decrease in oxygen transfer can be explained due to a decrease in hemoglobin count during the study. The drop in hemoglobin can be explained due to the large amount of IV fluids we gave to the sheep over the course of the study. When we normalize the oxygen transfer rate to hemoglobin count, this ratio is maintained over the course of the study, meaning that the patient were given, we were able to manage, if we were able to manage hemoglobin count more correctly, there would never have been a decrease in the oxygen transfer capability of our system. To monitor the coagulation ability of the sheep's blood during the study, we used 2 different metrics. We used the activated clotting time, or the ACT, and the prothrombin time, or the PT. ACT measures the amount of time it takes for whole blood to clot, and it's the most used metric to measure anticoagulation during ECMO because it's a relatively cheap and a quick test to run. Also, ACT machines are small, so they can be kept in the patient's room without getting in the way. They're about the size of a toaster. During ECMO, ACT is desired to be between 180 and 220 seconds. Prothrombin time measures how long it takes for prothrombin to convert to thrombin at near the end of the coagulation cascade. Compared to ACT, PT is better correlates to rivaroxaban plasma concentration, but it takes longer to measure. PT isn't commonly measured during ECMO, but the desired range for oral anticoagulants similar to rivaroxaban is 2 to 4 times whatever the baseline value for that patient is. During the study, we measured ACT and PT before and after the dose of rivaroxaban, which gives us the peak and trough ACT and PT times. Over the course of 10 days, we maintained an average peak ACT of 235.6 seconds and a trough ACT of 133.3 seconds. This is within the clinical range of ACT desired during ECMO. For PT, we were able to maintain an average peak of 46.1 seconds, which is 4.2 times the baseline, and a trough PT of 17.9 seconds, which is 1.6 times the baseline. This is also within the clinical range of other oral anticoagulant drugs. So these are representative images of the pulmonary assist system oxygenator after the completion of the studies. The left image is the inlet of the oxygenator. Blood flows from the right of the image into the oxygenator and then goes into the screen. And then blood comes from out of the outlet, from the image on the right, and the outlet comes out to the screen towards you, and then goes to the right and returns oxygenated blood back to the sheep. We weigh the oxygenator before and after the study to measure the weight of clot formation in the device. The average clot formation, at the average clot weight for our device was 58.55 grams. Most of the clot formation is on the bottom plastic housing of the device and not actually within the fiber bundle. There's very minimal clot formation that's actually on the fiber bundle. So ECMO has been shown to be able to sustain patients with severe chronic lung diseases for short-term usage as a bridge to a lung transplant. Using it for patients that will have to wait longer for a transplant has issues due to the risk of clot formation and bleeding, along with the patient requiring intense monitoring and having limited mobility. These issues require innovation in anticoagulation management and ECMO system solutions. Our work tackles these issues from different angles by research into anticoagulation coatings, factor 12 inhibition, oral anticoagulants, a biofabricated lung, and by developing a small portable ECMO system. We believe that the pulmonary assist system, along with the anticoagulant solutions we are developing, will allow patients to undergo ECMO with less monitoring, allow them to leave the ICU, allow them to walk, and hopefully in the future, allow them to undergo treatment at home. We plan on continuing research into the factor 12 inhibition and biofabricated lung, but the next major experiment planned is a study in which we will attach the pulmonary assist system to a sheep for 30 days. It is planned to start next summer and will bring together the use of Rivaroxaban, an electronic remote monitoring system, and a heart patch cannulation strategy. We are working with at other labs here at CMU and also a team at Vanderbilt University to try to bring together all these different technologies into one system, which we will then attach to the sheep for 30 days. So thank you. So I would like to thank NSBE Heisig for inviting me to present the research of our lab. And if you have any questions, please feel free to ask. Thank you for listening.
Thank you so much for your presentation, Patrick. At this time, we will open the floor to questions. Feel free to add them to the chat, or you can raise your hand, and I can unmute your mic. I will start off. Patrick, could you tell us why sheeps are used instead of any other test animal or test subject?
Well, sheeps are mostly used, mostly because one, they're easy to work with. They're very calm animals. But it's really the size of the animals that we're really concerned about to be able to fully transfer, try to transfer the capability of our devices to humans. So the sheep that we're working with, they're not small sheep. We're working with 150, 160. I've worked with a 220-pound sheep. So these are large animals. So that when we try to transfer the device from being used in animals to humans, the body size is the same.
Understood. And you mentioned that the a PCB coating is applied, and this helps prevent platelets from sticking to the surface.
Yes.
Can you explain how the PCB coating is applied?
So funny enough, it's as simple as dipping the device into a vat of the PCB in a solvent. and
Okay.
then it's dried. And that, even though it's just a thin layer, that's enough to prevent any platelets or protein absorption onto the surfaces.
Wow. Okay. That's simple enough. Okay. I'd like to open the floor to any other questions that we may have. Like I said, you can add your questions to the chat or raise your hand and I will unmute you. Okay, it looks like we have a question. What inspired you to do research in artificial lungs rather than other fields?
So it was mostly because when I came to apply to CMU from grad school, I looked at what the professors in different labs were researching. And my personal motto in life is do whatever you think is cool. And when I looked at the work that my professor, Dr. Keith Cook, was doing and the problems that he was trying to solve, just saw that like and thought, that's a really cool thing to do. I want to do that. So I thought it was cool, so I did it.
Great. Um, at this point, we'll invite Tim. Tim has his hand raised. Tim, go ahead, unmute yourself and ask your question. Tim, you there? Tim Burrows, the floor is yours. Okay. Let me check the chat. Okay. Tim's mic is not working. Okay, Tim, you can add your question to the chat.
Okay, so the question uh, is there any consideration for the internal device to be MRI compatible? So that's the interesting thing about ECMO. None of the systems that we are designing or making are internal. These are all external devices. The only thing that's internal is the cannulas that connect the pump and oxygenator to the vena cava. So also the actual oxygenator itself is fully made out of plastics. At least the device that we are developing. The only metal in the system would be the metal that's in the pump. So whether the pump would be MR compatible, I don't know. But the rest of the system is fully plastic.
Thank you, Patrick. We have a question from John Thomas. Can this innovation be applied to the pediatric patient population?
So that's very interesting. So pediatric ECMO is actually a pretty common thing. Uh, we there ECMO, especially for premature births, is actually pretty common. So uh, there are pediatric ECMO devices currently in the market. Uh, some devices that we're developing are uh, designed to be used for adults. but feasibly we should be able. I don't know if it's fully able to be scaled down properly, but scaling down should be an option for us to try to focus if we want to focus more on pediatric patients.
Thank you for that, Patrick. Any other questions from the attendees? Okay, so we will move on at this point. Thank you again, Patrick, for your presentation and sharing your research with us today. We are very grateful for your time, and we will move on to the rest of the presentation. So this is our introduction to our current e-board. These are all the people behind the scenes making HiSig run. When you get your newsletters and your email blasts and all of our contributions on social media, this is the team that is behind that and all of the programs that we put on for you, like the ones today.
Yeah, I realize. I eat a little bit.
At this point, we are going to talk about upcoming events and future outlook. This specific program is geared towards college freshmen and college sophomores. It's the Nimble experience. HiSig has been a partner with Nimble for quite some time now, and Nimble hosts a summer program for college freshmen and sophomore in any major related to STEM. But this specific summer experience is geared towards biopharmaceutical manufacturing. It is all expense paid, um, housing and travel. This year, there will be 7 locations hosting students. Um, One is at the Albany College of Pharmacy and Health Science in New York. The second is at North Carolina State in North Carolina. The third is will be held at the Puerto Rico Science, Technology, and Research Trust in Puerto Rico. The fourth will be held at Purdue University in Indiana. Fifth, Santa Clara University, California. Sixth, University of Houston in Texas. And last but not least, Worcester Institute in Pennsylvania. So please take this time if you know someone, if you yourself are a college freshman or sophomore interested in the biopharmaceutical field or even STEM related field. Please take advantage of this opportunity. Scan the QR code, which will take you to the registration page where you can register and submit your application for this program. The next upcoming event we'd like to talk about is the upcoming 2025 annual convention. This will be the 50th anniversary, so there should be a lot of celebrations geared towards this milestone celebration. Early bird registration ends December 14th, which is right around the corner. So we encourage all of you, if you can, to make efforts to be present. It will be held in Chicago, Illinois. So please look into making arrangements if you're available and if you can for the 50th anniversary. At this point, I'm going to talk to you about HiSig's ecosystem model. This is our way to try to reach as many of you as possible. The way we do that is to localize our care strategy. HiSig launches ecosystems in established and growing healthcare hubs across the United States that serve as extensions of HiSig in that area.
Yeah, if I could
Sure.
just for 10 seconds, I just want to illustrate the SIGs. This we have multiple SIGs, which are special interest groups. They are industry focused. I will highlight the high SIG, which is healthcare innovation special interest group. The SIGs are all nationwide. They are not industry specific or region specific. They are nationwide. So HiSig is across all 6 industries, across all 6 regions, actually, just like the other SIGs are. I want to highlight that and to just simply let you know that all 6 regions participate in all of the SIGs. And in tonight's context, the high SIG, the healthcare innovation SIG. So anyone of any across the country is welcome to participate and become an active, participating, contributing person to the healthcare innovation special interest group.
Thank you for that, Tony. Um,
Absolutely.
and as you know, just to piggyback on what Tony's saying, our HiSig e-board is made up of representatives from New York, the West Coast, Texas, Chicago. So we are spread out across the country. So feel free, no matter what part of the country you may live in, if you have interest in joining and participating, to do so. Your location, it shouldn't matter. And
Absolutely.
if you feel like participating, and we definitely encourage you to.
Absolutely, we do. All of the SIGs are nationwide. So feel free to join, inquire, question, and make requests as you see fit. Thank you, Mr. Mings. Appreciate that.
Of course, Tony. Thank you. HiSig has open positions on our board. Um, Feel free to scan the QR code on the screen, which will take you to the application. Um, your participation in HiSig can be as involved or as periphery as you'd like, but we encourage everyone, if you have a specific interest in the healthcare innovation field, to definitely scan this QR code, get in contact with us, and get involved. There's a space for everyone, and we invite everyone who's interested to come along and show interest, and we'll definitely find a spot for you. Last but not least, these are some of our past partnerships and also some present partnerships that we have, just to give a field of the wide range that we have in HiSig and in terms of our partnerships and the work that we do. So this is just to show you how involved we get in the industry and all of the companies interested in partnering with us to do good work.
And I'll just add 2 seconds of there's various degrees of integration amongst these partners. Some some partners we're doing something very specific. Other partners we're doing things more widespread. It's not a monolith. It's not a cookie cutter type of templated approach. It's whatever whatever the partnership dictates, we adapt and adopt to. So I just want to make sure that that's clear and clean and understood. Thank you, Mr. Mings.
Indeed. Thank you, Tony. At this point, I would invite if there's anyone else on the e-board who would like to say something to take the floor at this time. Okay, and on that note, I would like to thank everyone in attendance. Thank you for taking the time out of your day to attend, to listen to our presenter, Patrick Iyasele, in talking about lung device innovations. We're very grateful for his participation and making time for us today. Um, so thank you, one and all. Have a great evening, afternoon, depending on where you are in the country, and have a good night.
Thank you for all those who attended, taking your time out of your busy schedule to spend some time with us this evening. I agree with Mr. Mings. Thank you. Have a good evening. Much appreciated for your attendance.